everyone, and welcome to today's Lunch and Learn presentation, Why Breast Density Matters. I'm Peggy Schmidt, and it is my privilege as North Kansas City Hospital's President and CEO to welcome you to this educational presentation. We are very fortunate to have Dr. Christopher Formen, one of our wonderful radiologists, here today to talk about mammograms and breast density. He'll discuss the connection between breast density and breast cancer and share information on how combining your mammogram with additional tests can improve cancer detection and address the issues of breast density. Dr. Formen earned his medical degree from the University of Iowa School of Medicine, and he is board certified in diagnostic radiology and specializes in computer tomography, which we generally call CT. And also specializes in mammography, nuclear medicine, ultrasound, MRIs, and interventional radiology. Please join me in welcoming Dr. Formen.
Thank you very much, Peggy. Make sure this thing works, all right. So I'm Chris Formen, and today we're going to talk about mammography and breast density. National Mammogram Day. As we know, this is breast cancer awareness. So, yes, I did have my mammogram today. Why do you ask? Does anybody feel like that sometimes? Sometimes these things can be kind of a challenge. So first let's talk about breast cancer in general, or cancer in general. Cancer is a name given to a collection of related diseases. In all types of cancer, some of the body's cells begin to divide without stopping and spread into surrounding tissue. Cancer can start almost anywhere in the body, and your body is made up of trillions of cells. Now, people often talk about the fact that your body is constantly regenerating. So they say that every 7 years, you're a totally new person. Every cell in your body has basically grown up, aged, died, and been replaced. Now, that's not entirely true. Some of the cells don't ever do that, but most of you is new all the time. And so as a result, mistakes can be made. And when you get cancer, it only takes one cell that just goes a little bit awry, the internal mechanisms go off, and before you know it, you've got a cancer. So besides skin cancer, breast cancer is the most commonly diagnosed cancer amongst American women. This year, 30% of newly diagnosed cancers in women will be breast cancers. About 1 in 8 women. That's a lot, 12%. That's a lot. Look around. 1 in 8 of you may have to deal with this terrible disease. And so 1 in 8 women will develop invasive breast cancer over the course of their life. About 270,000 people will get new diagnoses of breast cancer this year. 62,000 of those will be non-invasive breast cancer. So about 41, almost 42,000 women in the U.S. are expected to die in 2019 from breast cancer. So it's a killer. I mean, it's a horrible disease. We have made progress as far as breast cancer goes. The rates are a lot less than they were. They've gone down gradually since 1989, but we've got some work to do. So, some more statistics. So they're higher, death rates are higher for breast cancer than any other cancer besides lung cancer. Of course, lung cancer is going down, right? Less people are smoking. We're going to see some progress. In 2019, more than 3.1 million women have a history of breast cancer that are living in this country. So, you know, if you think about that, the population of Kansas City is about 2.2, 2.3 million with the metro area. So that many people, plus 1 million more, have breast cancer in this country. Huge numbers, huge numbers. So risk factors. Why do women get breast cancer? Risk factors, anything that increases your risk of developing breast cancer. Many of the most important risk factors for breast cancer are beyond your control. You can't control your age, you can't control your family history, breast density, or your medical history. There are some risk factors, however, you can control, such as weight, physical activity, and alcohol consumption. So let's talk about weight. So being overweight is associated with an increased risk of breast cancer, amongst other diseases, right? We're talking about diabetes, high blood pressure, all kinds of maladies occur because as Americans, we get a little bit overweight. It's kind of our thing right now, right? So for women specifically, fat tissue is the body's main source of estrogen after menopause. Your ovaries aren't working as well, so you have higher estrogen levels. Estrogen is associated with an increased risk in breast cancer. So let's talk about diet. I'm kind of going to go off script here a little bit. How many of us have been on a diet? For everybody, right? Right? Okay, so how many of us have had diets that have worked? I have. Yeah, absolutely. So name me a diet. Just throw out a name. What's the name of a diet that's popular right now or has been popular in the past?
Keto.
Keto. Everybody loves keto. There's keto. Throw out another one. The what?
South Beach.
Weight Watchers, people like South Beach, right? And there's the paleo diet, and there's the zone diet, and there's a vegetarian diet. I've heard of an ice cream diet. And people actually lost weight on the ice cream diet, right? I mean, I wouldn't advise you do that, but apparently that works sometimes. And I talk about dieting because there are two things to remember about a successful diet. One, it has to be a diet that you can actually maintain. Right? It has to be something, if you don't like meat, Atkins, keto, paleo, that's not your thing. And if you don't like vegetables, don't do a vegetarian diet, right? The other thing is to not diet. Now, why do I say that? Because, we've all been through this thing, you want to go to your high school reunion, or you need to look good, and certain kinds of clothes, you're like, I need to lose some weight, I need to get on it. It's been too much, my pants aren't fitting right, I don't feel good. So you get on the diet. So what happens? You get on the diet, you do it for a couple months, and then I've lost the weight, I feel great, I'm going to go back to the way I was eating. So don't diet. It's about lifestyle change. That's just me getting up on a soapbox. It has a little bit to do with mammography, but more importantly for overall health. It's about lifestyle changes, right? Okay, so you want to keep your body weight in a healthy range for your height and frame. Body mass index is okay, that's not always accurate. Some of us have more muscle, and we're just built differently, but you can kind of see where you need to be. So exercise. The American Cancer Society recommends engaging in 45 to 60 minutes of physical exercise 5 or more days a week. So a lot of people think that means you have to go to the gym or you have to, no you don't. I mean, get out and walk. Just being active, riding bicycles. I mean, there are many ways to increase our exercise. And nobody associates these things with cancer, but really, these things increase your immune system, your ability to heal, just your ability to function every day, right? So these things are just as important as, the medical interventions that we have. Alcohol consumption. Studies have shown that breast cancer risk increases with the amount of alcohol one drinks. Alcohol can limit your liver's ability to control blood levels of estrogen. There's that hormone again, right? So just keep it in check. I love wine as much as anyone. A glass every once in a while is okay. A couple bottles, probably bad. Okay, so smoking, we all know that's bad. That's kind of self-explanatory. Gender. We can't help what gender we are. Now, breast cancer does occur in males, but it's much less common. Where you folks are 1 in 8, my folks are about 1 in 1,000. So we have to be vigilant when it occurs, but the risk is just higher being female, obviously. Family history. If you have a first-degree relative, mother, daughter, sister who has breast cancer, or you have multiple relatives affected by breast cancer or ovarian cancer, your risk goes up as well. So there is a strong genetic component. Personal history. If you've already been diagnosed with breast cancer, your chances of having it again go up. That's kind of a bum deal, right? I mean, unfortunately, that's the case. So if you have breast cancer, your chance of getting it again is a little bit higher. And breast density, we're going to talk a lot about that as the talk kind of insinuates. It may increase your risk of breast cancer by 1 to 2%, just having dense breasts. There are more tissues and are more susceptible to evolving into cancer. But the jury's kind of out on that. So 1 to 2%, that's not that big of a deal. The larger issue is it's harder to see through dense breasts, as we will talk about. Okay, so you've heard of these BRCA genes, and those are the inherited genes that occur in about 10% of women. You have the gene, you're almost always going to get breast cancer. I mean, if you have those genes. And usually you will know because that family history is so strong in these women. Like my mother had it, my sister had it, my grandma had it, everybody has it. So you go get the test, there's great testing for that, you find out that you have the BRCA gene. Okay, and there's also increased risk of ovarian cancer as well with some BRCA genes. So, does this look familiar? Like, who's had their mammogram this year? Everybody had their mammogram? Do you have to go through a psychological prep to get it, right? Do you have to prepare yourself, get into your zen place, run against the wall, run against the car, beat yourself up just to go for the pressure of the mammogram? After a while, I dare say you kind of get used to them. Not the most fun thing in the world, but oftentimes we need to psych ourselves up to get it, right? So what is mammography? So a mammogram is an x-ray of the breast. Mammograms are used to check for breast cancer in women who have no signs or symptoms of the disease. It is the ultimate screening test. You're perfectly healthy, you're perfectly fine, there's nothing wrong with you. And that's when we want to look, because if there's something there, we want to catch it at the earliest possible stage. So this type of mammogram is called a screening mammogram. Screening mammogram usually involves 2 x-ray pictures or images of each breast. These images make it possible to detect tumors that cannot be felt. You can see tiny little microcalcifications, which can be a sign of cancer. You can also see little masses or things that we call architectural distortion, just areas of the breast that look kind of funny. So here's a picture. These are what we call MLO views. Now, this is pec muscle right here. The dark stuff is fatty tissue. The bright stuff is what we call fibroglandular tissue. Now, the breast is a gland. I mean, even though we forget this in our society, breasts are made to make milk. That's their purpose. So they have elements that do just that. Unfortunately, some of the cancers and calcifications can also hide in these white elements. So the more of those elements you have, the harder it is to get to what's underneath it. Okay. So diagnostic mammography is kind of the next step. So that checks for breast cancer after a lump has been found. Besides a lump, you can have other signs of breast cancer, which will include things like pain, your breast hurts, you don't know why, the skin gets thick or turns a different color for some reason, breast discharge, just a quick note on that, clear discharge is not as big of a deal, a little bit of milky discharge, a little bigger deal, bloody discharge bad, right? Okay, so we do diagnostic mammograms to evaluate for changes found during a screening mammogram as well. So you come in and sometimes your doctor will say, hey, I need to take more views. At North Kansas City, we offer same-day screening. So you can come in one day, get your screening mammogram that same day. We can say, okay, we need to do more tests, and you can get them done while you're there. So you don't have to go home, have the anxiety, what's wrong, get the letter, and then come back to the hospital. So it's helpful when it's difficult to obtain screening mammography because of special circumstances. Say you have breast implants, say you have a pacemaker, say you've had surgery, you may need other views. It also takes longer than a screening mammogram because you need more imaging, and usually different views, as we talked about. You may also need ultrasound. Ultrasound is not just for babies. Ultrasound uses sound waves. It's a really good way to look at breast tissue as well, particularly dense breast tissue, as we'll talk about. It's good for cysts or solid masses and lymph nodes. In some cases, we have to use MRI, a really fancy machine that kind of uses a bunch of different things to look at tissues in the body. But we have all of those things available in North Kansas City. So now, the most common form of mammography that we use is 3D mammography, 3-dimensional mammography. So it takes multiple images of the entire breast. A conventional mammogram, like we talked about, produces overlapping tissues. Again, it's hard to see through a 2-dimensional image that you can see on a piece of paper. 3D mammography allows mammographers to examine the breast tissue in layers. So I like to use the analogy of an apple. So let's say you have an apple. The apple represents the breast. Inside the breast, you have cancers. Inside an apple, you have seeds. If you slice that apple up individually, it's easier to see those individual seeds than trying to look, as opposed to trying to look through the whole thing. So 3D mammography does exactly that with your breast. It slices the breast into individual slices so that basically we can look at little tiny details and you don't have all that overlying tissue obscuring anything that could be hiding underneath. Okay, so the benefits of 3D over 2D mammography. Research on 3D mammography shows that it increases your detection of invasive breast cancer by 40%. It reduces false positives, so people you think have cancer but really don't, it gets rid of some of those people by 15%. You also have a decrease in callbacks, for diagnostic mammograms, sonograms, MRIs, and that, the less time you have to spend in the hospital, the better you feel. I work there and I feel that way sometimes, right? So more 3D benefits over 2D mammography, earlier detection of small breast cancers, greater accuracy in pinpointing size, shape, and location of abnormalities, fewer unnecessary biopsies or additional tests, greater likelihood of detecting multiple breast tumors. So we really like our 3D mammography. Now breast density. So every time you get a mammogram, have you guys ever noticed that, well, if you read your report at the top, it'll describe what your breast tissue is like. It'll say almost entirely fatty all the way to very dense. So we categorize those in 4 categories. So 10% of women are category 1, are almost entirely fatty breasts, just like that picture I showed earlier. About another 10% of women are all the way on the other side of the spectrum, where they have very, very dense breasts. Most of us lie somewhere in between. So here's this graphic. So here we can see this breast is almost entirely made of fatty tissue. These are actually little vessels that are going through the breast. Here, this is a little bit more density. You've got some dense tissue here. Here you've got even more. Here the entire thing is almost always dense tissue. Now, luckily, when we're younger, we tend to have more fibroglandular tissue. As you get older, some of those elements kind of go away, so it gets a little bit easier to sort through this stuff. But like we talked about, 10% are here, 10% are here. Everybody else is kind of in between. And it's really not this area or this area. These are easy to read. When I see a breast that's almost made entirely of adipose or fatty tissue, I'm happy about it. I'm like, this is awesome. I mean, this is easy. I can see everything in this. When you get one of these, you're like, okay, this might be a little more of a challenge. Let's use our 3D mammography. And let's use something called ABUS. So ABUS is a technology we use to look specifically at breasts that are of increased density. When used with mammography, it can increase detection rates by about 30%. Now, we saw those numbers earlier, right? I mean, we're talking about hundreds of thousands of women that are going to be diagnosed with breast cancer. Any tool we can use to increase our ability to detect cancer at an early stage is something we have to be interested in. So if you get a letter back from your doctor that says you're one of those women that have those breast densities that are on that side of the spectrum, then you can qualify to use ABUS. And it's a screening exam just like mammography. So when women come in every year, you get your mammogram. I have dense breasts, so I also get my ABUS. It uses sound waves to generate pictures, so there's no radiation. That's a benefit. Oftentimes people are worried about the radiation you get with mammography. And it's not that bad. I mean, it's kind of like flying across the country on an airplane. That's the amount of radiation you get equivalent. But there is no radiation with ABUS. So here's a picture of what it looks like. I don't know that you're going to smile that much. This lady looks a little too happy because there is a little pressure involved, but it's not quite as uncomfortable as having a full-on mammogram with that amount of compression. And I know most of you are looking at me saying, how would you know? But that's ABUS. So just in closing, at North Kansas City, we have a full-service, state-of-the-art women's imaging center. You can come there, get your 2D mammogram, which we don't really even do that much anymore. We're doing mostly 3D mammography, right? You can get your ABUS if you're one of the ladies that happens to fall into those categories where you might need an ABUS. You can get your breast MRI, you can get your stereotactic biopsy. So, when I'm working there and I'm on mammography, there are days when I'll do 3, 4, 5 of these a day. We just we're good at it. We've got a lot of experience with it. And fortunately for you, as a patient, this is the place where you can go get your screening mammogram. All right, you've got something wrong. Get your diagnostic mammogram. All right, heaven forbid, you need a biopsy. Well, the surgeon's right upstairs in the same building. So it's essentially a one-stop shop. You don't have to go one place to get your mammogram, another place to go get your biopsy, then the third place to go get your surgery. We have everything contained there. And I think that limits the amount of anxiety that patients have. And I feel like they like the fact that they can see the same familiar faces, going from department to department. So, incidentally, we also perform obstetrical and gynecologic ultrasound in the same facility. So that facility is, just a women's center. Every once in a while you'll see a man there, because like we talked about, 1 in 1,000 may have some issues, but it's just for women. So I think that makes everyone a little more comfortable. So if women-controlled medicine, what would a mammogram look like? I don't think this is cool at all. But every time I show this to someone, they go, you know what, I wish we could do that. Wouldn't it be nice if you guys had to go through what we go through? So yeah, I can't wait to get my mammogram. Okay, thank you.
Don't sit down, Dr. Formen, because we have time for some questions. So if you raise your hand, and then Dr. Formen will
There we go.
recognize you.
So, you guys have protocol in place if someone has been diagnosed with breast cancer and they're doing their yearly diagnostic mammograms, getting the MRIs done every 6 months?
Well, it
If
depends.
they do have dense breast.
It depends. So, like, if you do have dense breast and your clinician recognizes that, or you recognize it and say to your clinician, hey, I'm really dense. With my diagnostic mammogram, can I get an A-bus? That'd probably be the way to go, as opposed to an MRI. MRI looks specifically for like really subtle things and things that enhance a lot and have a lot of blood flow, so it's a little more difficult, a little more time intensive. And I'm not sure the insurance will pay for that on a screening basis, but an A-bus they will. So if you know someone like that, or if you're like that, yeah, absolutely. Talk to us and we can add that to your exam. So that's a great idea.
Radiologist where I go came up with a recommendation that get the breast surgeon. I was like, there's no point.
Yeah. And sometimes it takes time to get everybody on board with this, because this is a fairly new technology, but do you come see us?
No.
Oh. That's what you get. No,
I was curious if that was protocol
Yeah.
radiologist.
well, it's not built into a protocol, but it is something that can be used, for sure.
So what is the difference between an A-bus and a breast mammogram?
Okay, very good question. So an A-bus is automated breast ultrasound. So that means once that plate, I showed that picture with the lady laying down in that plate. Once it's put down, the sonographer doesn't really have to do anything. The plate moves itself in a predetermined fashion, and every time you get one, it moves the same way. So a normal ultrasound that's done with a sonographer is a lot more operator dependent. So they're looking all over the place, right? And a lot of times, because we draw the breast up into a clock face, and then sometimes we're looking at 4 o'clock. So this takes away some of that, so that it's automated, it's always the same every time. We like consistency in radiology. We want everything to be the same every time.
Is
So.
one Kansas City hospital that does it?
No, there are others that do it. Yeah, it's fairly common. It's fairly, KU does it, St. Louis does it. Yeah, all the major hospitals do it. Yeah. Oh, yes, I'm sorry. Go ahead.
No, actually, you mostly answered my question. It had to do with the protocol
Okay.
on asking for the A-bus. Who does it? Whenever, I've never heard of this from my primary care physician. I get all my done in Kansas City.
Okay.
I've never heard them say this to me, and I'm not as far as having, sure do laundry, I don't know.
Share your business. We're all friends. Right?
Yeah, well, there's been some issues in the past that I luckily did not have breast cancer. But I have very thin
You do. Okay. So
that from the get-go.
yeah.
So this is something that I can ask them to put on my file of some sort at North Kansas City?
Yes, you can. Just the next time you're going in to get your mammogram, just ask your doc, say, and most of them, they may be aware of it, they just may not use it very often. I mean, we're creatures of habit, so we like the things that we're used to. But if you bring it up and you were to say, okay, I'm getting a screening mammogram, I know I have dense breast, so how about the A-bus? Can I get that when I get my screening mammogram? That's the way we're seeing most of these things come through. Patients asking, or some doctors know about it, but not everybody's on board quite yet. So just ask him or her, and I think maybe we can get that taken care of that way.
Thank you.
So are you using the ABUS for the diagnostic mammograms?
Yes, sometimes, yeah.
Is insurance covered?
The ABUS.
Sometimes, not insurances, right? They used to, yeah.
So doesn't.
Most of the time they do.
From what I found from the 2D to the 3D, which I just took my first 3D this year, it eliminated me having to have the sonogram because,
Sometimes
so
it
I was
does.
doing 2D, and
Yeah.
I always had to do the sonogram. When they went to the 3D, they said, no, you don't have to have a sonogram.
I like ABUS. 3D mammography is revolutionary. I mean, it's another step in kind of the progression of radiology for a breast imaging, I think. Yeah, it's awesome. It's awesome. Yes, ma'am.
I have two questions. Can you get the ABUS without getting a mammogram?
We don't like to do that. And here's why. So mammography is really good at looking at certain things, specifically areas where, I talked about that fibrous tissue, areas where that tissue is really irregular, it's kind of hard to see on ultrasound, and it's really good at looking at calcifications. Calcifications are hard to see on ultrasound. Are you all familiar with that term, calcifications? I talk to patients a lot about this, and I kind of like to explain why you get them and what they actually mean. So, when cells die in your body, we've talked a lot about cell growing and cell death. When cells die in your body likes to turn the products of the cells into calcifications. So getting calcifications in and of themselves is not necessarily a bad thing. It's a way your body kind of recycles things, right? It takes that calcium, puts it back in your blood, and you use it just like you would any of the other minerals you use. The problem is that when cancer grows and dies, it does it very rapidly, and it also makes calcifications. Those calcifications have a pretty specific look, but sometimes there's some overlap between normal calcifications that you have just with aging and cell death, and calcifications that occur because you've got a cancer that's rapidly growing and dying. That's why calcifications are so important. So when you hear a doc say, there's some calcifications in this part of your breast, be vigilant about that. Follow those if they need to be followed. If we say they're benign and they're fine, don't worry about it. But calcifications are an important part of what we do, and you can't really see that sonographically.
Okay. The other question is, some of my friends have been told after they became 80 years old, they did not need a mammogram by their doctor.
Yeah.
And that's what I want to know, because I turned 80 this year.
Yeah. I hate to see that because I think it's up to you. So breast cancer in particular is kind of funky, and then it kind of ramps up. And then once you get to a certain age, it kind of starts going back down, right? And it becomes, again, because as we age, different things happen, I think it kind of just depends on you, kind of your family history, how you feel about it. I mean, I certainly would tell someone, no, don't come back in. There are different 80s, right? I mean, I have a friend that's 80 years old who I can just now barely beat in a bicycle race. So, I mean, there's different levels of 80, right? Yeah, so I think that's kind of up to you.
I have a question. What is the cut-off age for a person to have a mammogram?
To start,
The cut-off, like how old?
oh, that's kind of what she's in. There is some literature out there that says, when you're in your 80s, you probably don't need to do it anymore. A lot of that may be, even if you were to get breast cancer at that age, probably something else might get you. I mean, that's what people are thinking, I think. But having said that, I mean, because you can, and depending on the type of cancer, some breast cancers are, you can live with for a very, very long time, and a lot of them are cured. So that's kind of the thinking, I think. They're looking at life expectancy.
When I turned 75, and he told me that I didn't need a mammogram anymore because my mammogram has been negative for the past 5 years.
I know people say that. We don't say that. We don't say that. Because we don't. I mean, even if it's in the literature, even if there's some thought, I think that it all depends on the person. So as far as we're concerned in North Kansas City, give me 102. I'll read your mammogram. Okay?
that the AMS was answered, but I have a question. So I do the mammograms through Lincoln City, and I get the letter that says, you're fine, whatever. And does it make a recommendation if it says that you have breast density for the ABUS, or is that something your regular clinical, everyday doctor has to
Good
do?
question. Yeah, we're putting that, and when I see a dense breast, I put in on the bottom of my mammogram,
Okay.
recommend screening with ABUS as well.
Okay.
I put that as part of the recommendation, so we're doing that more and more commonly. I think a lot of places do it, not all the time, so you may get through and not have that recommendation, but if you have dense breast, that's something I like to put in the report.
Another comment relating to this lady's, I had a friend whose mother was 82, and she developed breast cancer, so I don't think that's a wise idea.
I don't either. I don't, but it's hard to go against what people,
Right.
your doctor's telling you. Yes, sir.
I don't know if it's different locations, but we live in Florida, Florida, and they will not give a woman that.
They do that in Europe, they do that in Canada as well. In Europe, they like to do the 2-year thing, where you go 2 years in between mammograms. They tried to pass that here, of course, as Americans like, no. And just, as anecdotally, as a physician, I see cancers all the time that pop up in a year, in a couple of months even.
This is what she was going to ask me about.
Is what?
My wife is 80 and she's gone through this in Florida. They will not give it. So how does Medicare be different in Florida?
Yeah. I'm not sure. I'm fairly certain we see a lot of women over the age of 75 and it gets paid for. So
She ends up doing the periods.
there you go. Yeah. Move back just in the when it's nice, right? In a couple months, I'm going to want to be in Florida, so I'm going to come stay at your house. Yeah. Sometimes it may depend on kind of who's reading it. There's some variation there. It could be projectional. Sometimes the way you're placed in the mammogram. Again, that's what I like about that ABUS, like we talked about. It's always the same, right? When you get a mammogram, sometimes your breast density can look a little bit different. So that may be some of that. And sometimes it's not always the same radiologist who's interpreting the exam. So there's some variation there too. Sure, I think that would be reasonable. Especially if you know you've had dense breast in the past. You did. Okay. And also I should add that sometimes breast composition changes, like we talked about with aging, your breasts tend to get less dense. So it could be that your breast is getting less dense too. So.
When a patient presents for how do you decide whether to do 2D or 3D?
We try to get everybody to do 3D. There's really no downside in doing. Sometimes women can, the compression's a little bit longer, it takes just a fraction longer, or sometimes women just don't want it, but since everybody's paying for it, there's really kind of no reason not to get it. It's kind of the standard of care now.
It's my understanding that there's a little bit less pressure with 3D, and that some of the newer machines have a curve.
Yes.
Plates
Yes.
that are comfortable.
Joe?
Yeah.
We're
We should have the curved paddles in just a few weeks, actually, in the month of November. Right here, we have to be publicly announced.
So you remember that first slide I showed, right? Now they're not going to be flat, they're going to be curved.
So how's the picture different than if you start using these curved?
Well, the picture will be the same. I think that's a comfort thing. Yeah, it's a more comfort. Yes, ma'am.
Are dense breasts the same as fibrous breasts?
Yes and no. So dense breast can be made, so what you're talking about is what we call fibrocystic change, which is associated with both fibrous tissue and cysts a lot of times. So dense breast can be, but it's not necessarily just, there's a lot of elements in the breast. We kind of try to simplify it by saying, oh, it's, fibrous tissue, but there are a lot of other elements as well, so it can be. This is the best answer.
So can you guys kind of tell if it is actually a tumor or a cyst from the 3D?
Yes, that helps, but that's where sonography comes in, because sonography is even better, specifically for cysts. So on your A-bus, or when you get a handheld ultrasound, so like if you get a diagnostic mammogram, a lot of times you'll be sent back to the ultrasound room, and the sonographer will take the probe, and she'll say, all right, we're gonna look at this and see what it is. We're almost always doing that to differentiate a cyst from a mass, because that's really hard to do on mammogram. But an ultrasound, that's easy, it's easy.
The MRI, it lit up.
Yep.
You know, you had to go for like a second biopsy, but it came back nothing,
Good.
so I was like, oh, mammogram, and maybe they want an MRI. Permanent or something.
Or a combination of all three. I mean, it's kind of like the more tools you have to throw at this disease, the better off you are. I mean,
You're doing a lot more lymphadenectomies now.
yeah.
I didn't deal with your lymph node. But we have a niece in Nebraska, and she thought she was already in the license. And she thought she was going to have the breast removed. She was like, no, they were doing all the radiation and stuff. Because society, is that normal?
It is. So it seems intuitive that if you have breast cancer, a lot of times it'll just be easier. We'll just take the breast, right? I'll get new ones, It seems a lot easier to do that, but a lot of research has shown that there's no change in basically mortality or the number of people who end up passing away from breast cancer using a total mastectomy as opposed to a lumpectomy. The numbers are kind of the same. So that's why they do that a lot. Having said that, a lot of surgeons, if you want a mastectomy, they'll do it a lot of times. So I think you have to ask.
Let's once again thank Dr. Formen.